Hi, everybody. I'm Ann Schaeffer. I'm one of the faculty here at Eastern Mennonite University, and I want to congratulate you all on being ready to begin your DNP. It's a very exciting time. I can relate. I just completed my DNP through Frontier Nursing University in December, and so I'm both excited for you and want to encourage you that you will get through this. What I'm going to show you today is a brief presentation of my project. This was the presentation, this is not the final project presentation, it is which was a lot more formal. This was the presentation we gave at the end of our implementation before we did our dissemination. So this was a Pecha Kucha style presentation, which if you've ever heard of, it's each slide contains an image rather than a lot of words. And so you'll hear me talking and explaining as we go. Two abbreviations I use frequently in this presentation. One is SBIRT, Screening, Brief Intervention, and Referral to Treatment. In the quality improvement world, you'll hear that a lot. You'll also hear me referring to PDSA cycles, which are Plan, Do, Study, Act cycles, which if you're not familiar with yet, you will be soon. And the final abbreviation is PHQ, which stands for the Patient Health Questionnaire, which is a commonly used brief screening tool for depression. So at this point, I'm going to go ahead and share my screen with you all, and we will get started. Okay, so this is my project on improving the efficacy of depression screening for the Harrisonburg Community Health Center. We are located in the Central Shenandoah Valley. This is a refugee resettlement area, and therefore we have an incredibly diverse community. Even though my specialty is women's health, my center's QI priority was to improve their depression screening and follow-up rate, which had been quite low for some time. Therefore, I found myself designing a project on depression and arrived at the aim to increase the efficacy of depression screening through SBIRT for screen-positive clients to 75% or more, and I needed to do it for a diverse multilingual community. For planned changes, I needed to engage my team. I planned in-services, multidisciplinary planning meetings, and held a contest to name the project, posted project updates, and shared patient stories. Teams also engaged in self-evaluation throughout the project. I wanted to engage patients in shared decision-making, and my team chose the option grid as the brief intervention tool to use. A great team of interpreters translated it into Spanish and Arabic, and later warm handoff education for patients was added to the tool, also in 3 languages. At HCHC, the PHQ was administered verbally, but an interpreter shared her concern that asking the questions aloud is often not culturally appropriate and may be resulting in false negatives. I planned to trial written PHQs in 6 languages. These were organized in so-called blue books and placed in exam rooms at the point of care. Finally, a right care tracking log was created and patients who consented to follow-up were entered. Chart audits, follow-up phone calls, and data on follow-up was collected to guide best practices. I predicted that over 90% of staff would receive education and teamwork scores would increase by 20%. For patients, I predicted that shared decision-making and documentation of choice of care plan would reach 80% and that appropriate depression screening would reach 90%. Finally, I predicted that at least 70% of patients would have documented evidence-based plans of care and that compliance with follow-up would increase to 70% or more. In terms of results, I'll start with my aim, which was met, even achieving 100% on a few clinic days. To meet the aim, a patient had to be appropriately screened as positive on the PHQ, have documentation of shared decision-making, and an evidence-based plan of care, including a plan for follow-up. So how did we get here? Over the course of the project, 94.1% of the staff received training and education on depression screening, surpassing that goal. But working around summer vacations and staff turnover was a challenge, which also caused a drop in some teamwork evaluation scores. And so ultimately, the 20% increase I hoped for did not occur. Meet Nellie and Laura, 2 clinic staff. They have stopped in at a breakfast to celebrate the project halfway point. This provided an opportunity to educate and update the team and provide them with a new screening trigger called the Smiles cards. Both providers in this project became successful in documenting the patient's choice of care plan, surpassing the goal and even reaching 100% on several occasions. What made the difference was creation of a positive PHQ template in eClinicalWorks, which is our EHR. This prompted quick and correct documentation. Our population has many risk factors for depression: refugee or forced immigration status, lower SES, and other chronic illness diagnoses, especially diabetes, anemia, and asthma. So I was not surprised to find that the positive PHQ rate in our clinic is not actually the 16% from baseline data, but closer to 50%. One challenge was that halfway through this project, the care coordinator abruptly resigned. Until new processes were put in place for pre-visit planning, a drop in the rate of identified depression was observed. Starting in cycle number 2, chart audits were conducted on kept follow-up contacts. Using guidelines from the U.S. Preventive Services Task Force and the CCNC Toolkit, providers were documenting right care for patients most of the time, but compliance with follow-up had a baseline around 40%. This outcome was able to be increased between 60 and 80%, and it was continued to be tracked through early October. A deeper look at the tracking log data showed that about 60% of clients consented to be followed up. Now, of these, we achieved complete remission of symptoms for about 16% of the patients we saw. And this is perhaps not a huge number, but yet it's very encouraging given the relatively brief length of this project, and we hope to see that number increase over longer periods of time. To summarize, the timely screening of depression revealed increased prevalence in this population. Intentional patient engagement seemed to improve screening and follow-up and may have resulted in faster remission of symptoms. Team commitment was consistent throughout the project, although sometimes challenged by staffing turnover and summer vacations. But overall, we were able to achieve our aim. During this project, I learned that screening drives chronic illness care. When the screening rate would drop, fewer patients with depression were identified, and therefore fewer received appropriate referral to treatment. I learned that perception of effective teamwork is affected by daily variations in staffing and pre-visit planning. And I finally learned that when patients are engaged in their care in culturally appropriate ways, improved compliance with follow-up and remission of symptoms seem to be more likely to occur. In terms of impact on the system, depression is much more prevalent than previously thought for the entire community and needs to be screened, treated, and managed like any other chronic illness. This project demonstrates that multidisciplinary teams can bring about great change. This implementation can be used as a model for other primary care settings, a model within HCHC for care coordination, and should help grow the behavioral health services at HCHC. In conclusion, it is promising that the screening process, understanding of right care for follow-up, and the use of shared decision-making have all been improved for 2 care teams. With coaching and resources developed by this project, other care teams at HCHC can begin to implement right care for depression. Tracking for positive PHQ patients should continue, but will benefit from an eventual transition to an electronic method that works with our EHR. As I reflect on this project, I realize I have come a long way since the last time I was a Frontier student. I also know that the faith that HCHC had in me as a DNP leader enabled me to take on this project and succeed. I have become a huge fan of multidisciplinary care teams. For example, the internal name for this project was chosen by a billing assistant, the SMILES Project, which stands for Screening More Individuals, Less Emotional Stress. I strongly believe that when everyone on the team is engaged, great things can happen. When I began this project, I could not see the path ahead, but my site believed in me and I believed in my team, and now I know that we are prepared to take better care of those in our community who are the most vulnerable. Thank you. Okay, so that was my project, and since I've done that presentation, I have of course gone on to do my final project presentation and defense. I have actually presented that project at one professional conference, and I'm scheduled for another one in April, and it has been submitted for publication to a journal. So best of luck to all of you. I know you can do it. The key is just to begin, and you'll get there. Take care.